like to thank the Society and Mileden for this kind invitation. It's really a pleasure to be here. Thanks for having me. I'm just gonna show a couple of videos regarding splenic flexure mobilization. It's our goal to restore the ball continuity with maintaining a good blood supply, avoiding the tension, and in order to do that, we need a compliant segment of descending colon with the precise surgical technique and the common sense. But there are problems with the sigmoid because the average sigmoid wall is thickened and it is stiff, not compliant, which may cause low anterior resection syndrome. There might be full of diverticular disease because many of the rectal cancer patients is aged over 50 and it's possibly irradiated and its mesentery is fat, short, bulky, and its marginal blood flow is hard to see if you don't have the facility to use inducing green or fluorescein angio. So when we remove the specimen, we want to just move the descending colon, and we have to make sure that there's no tension at the anastomosis. So we check the anastomosis, and then we do a stapler anastomosis, and then we do an air leak test, and we have to make sure that no tension, it's free of tension, and do the air leak test. But however, some may leak. And it causes problem regarding the surgical point of view. It may affect the adjuvant chemotherapy as well as the functions. And this is the blood supply when we take the inferior mesenteric artery and then the left colic and then the inferior mesenteric vein, and it really depends on the marginal blood flow. And in order to, before making the anastomosis, we must make sure that there is enough blood supply. However, as you see here on this slide, the leakage rate is significantly high if you are doing an anastomosis in the pelvic floor, up to 20% in the literature when we look to TME series. This is a case, as you see, when you're doing a case like this, you may need a splenic flexure mobilization after taking down the inferior mesenteric artery. And then, I do apologize for this technical problem, but afterwards you're trying to take the inferior mesenteric vein. But be aware that there are some variations, although many know that inferior mesenteric artery's vein is always there, but there might be an artery accompanying the vein, and this may cause problem. And here I realize the artery, so I try not to cut the artery or transect the artery and try to look at the vein and try to mobilize the vein. I really do sorry, but I tested before this, but I don't know what happened now. And we put clip and the other clip, and then you see it's my fault. I start bleeding from that artery, so I'm in problem. I put another one, so I damaged the blood flow of the descending colon, which I transected and then put another clip. Control the bleeding, but I lost the lens. Now there's a demarcation, and it prolongs the operation further 1.5 hours to get all the transfers and the splenic flexure and everything and make it reach. And I did it, but shouldn't be like that if I be a little bit more cautious about it. So, as you see, after the mobilization, we did the anastomosis, and this is again tension-free anastomosis. So we must be aware that there is a possibility of accompanying artery next to the inferior mesenteric vein. If you want to do a splenic flexure mobilization, you must be aware of that. So when we look at the literature, although it is more than 200,000 years old, there are so many synonyms around it. And as you see, look at the names of the rheolan. It's still confusing because all these names is using and the name of rheolan, but it's not true. So we have to stop using rheolan arc. So we have to do a real definition for intermesenteric communications, and we have to know the frequency of it, and we have to know the impact of it. So in our study, we did classifications in order to use for the clinical research, for clinical purposes. So there is the marginal artery, which is always there next to the colon. There are intramesocolic communications, and there are central communications. When I say central, it is just next to the inferior mesenteric vein during the clipping, and it is just next to the duodenum. And when we look at the literature, these are the studies starting from very early in the 20th century. It is around up to 18%. But none of these studies really looked at where it is from and where to where. These are mainly arterial, cadaveric, or mainly angiographic studies, and they didn't say the communications from where to where. So, normally it is the inferior mesenteric artery, left colic going the ascending branch, and this is the inferior mesenteric vein. And when we look at the cadaver, this is the inferior mesenteric artery, this is the marginal artery, and this is the left ascending colon goes and connect with the middle colic artery. This is the normal anatomy, but variations still exist on this part as well. This is the one of the central anastomosis. This is the accessory middle colic artery, which is communicated with the left colic artery, and this is shown in this view. It is the inferior mesenteric left colic, and this is the inferior mesenteric vein, and next to it there is an artery. Since we dissected it, it looks separated, but it was just next to it. We dissected it because we want to know where it is originated and terminated, and this is the superior mesenteric artery, and this is the accessory middle colic because there is the original middle colic artery. And this is another type. It is from the left part of the middle colic joining with the left colic artery, and this is the inferior mesenteric left colic, ascending left colic artery, and this is the, as you see, the communications between the left branch of the middle colic with the accessory left colic artery. And this is another type from the root of the middle colic artery and the left colic artery, and this is connection. Again, highly important. If you divided all these, you will have ischemia like that had one happened to myself. This is the, as you see, the communications between the middle colic and the left colic artery. It's a very significant artery there. And another one is different because we haven't came across in the literature, and out of 107, there are no middle colic arteries at all. And it is an iliocolic artery supplying all the marginal arteries and communicate with the left colic artery. Here is the superior mesenteric artery, left colic as iliocolic artery, and iliocolic, as you see, comes from and just goes around and communicate with the left colic artery. This is just the inferior mesenteric vein and the artery. As you see, there's no, again, middle colic artery there. And another one is the branches that supply just directly to the marginal artery. This is the accessory middle colic artery, and it goes directly to the marginal artery. And this is, again, another problem if you just follow it and transect it or clip the inferior mesenteric vein, and next to it there is the accessory middle colic artery. communicate with the marginal artery. This is the left colic branch joining the marginal, and this is the accessory one joining the marginal. Here is the pancreas, and this is the accessory middle colic artery, goes and directly communicate with the marginal. And when we talk about the intramesocolic, actually this is one of the definition of the Riolan. It is a parallel communications, but not next to the inferior mesenteric vein. So the surgeon can divide two different communications, one central next to inferior mesenteric vein, one intramesocolic, which means there's no accompanying inferior mesenteric vein, and the marginal, the third one. And here, as you see, it is the left colic, the ascending branch. This is the transverse colon, and this is the, as you see, a parallel artery, not accompanying the inferior mesenteric vein. It communicates with the middle colic, but not next to the inferior mesenteric vein. I really do apologize for this technical problems with the video. And here, what I have learned from Amjad, I must say that this is the way we do splenic flexure mobilization. This is the animation showing, and it's good for the residents and our senior registrars to follow it beforehand. It shows and delineate the anatomical structures. This is the inferior mesenteric vein, and we are taking down the inferior mesenteric vein next to the duodenojejunal junction and the inferior border of the pancreas. And don't forget that there is a 12% chance of central communication. It's not very low. It is 12.2% in our series, more than 100. And then we just incise the border of the lower aspects of the transversalis fascia and find the pancreas, and then mobilize all the splenic flexure. So this is followed by cadaveric dissection. As you see, there are inferior mesenteric and aortic plexus around the inferior mesenteric artery. When you just go underneath the superior rectal artery, you must be aware that not to damage the autonomic nerves. And when you follow the parallel to the duodenum, you will find the pancreas and the renal vein. You can come across just the inferior border of it, but you have to just go at the superior border of the pancreas in order to reach the bursa mentalis in such situation. This is a thin cadaveric dissection, but showing the nicely anatomical structures in a better way. And this is the perineal fascia, and this is the visceral fascia, and we are opening the posterior bit. This is another cadaveric dissection showing the same approach. We divided the inferior mesenteric artery. Be aware that there is the intermesenteric communications showing that it's next to the inferior mesenteric vein, and there is the position of the cadaver. And then we divide the inferior mesenteric vein, and we reach the superior border of the pancreas and incise the transverse mesocolon, and it allows us to reach the bursa mentalis, and it really is the splenic flexure mobilization from the lateral side, as you see clearly. And then you start from the lateral and protect and avoiding damage to the spleen, and then you ended up with a full mobilization. If you need to, you could use for a very low anastomosis or hands to coloanal anastomosis. And in the live surgery, this is the inferior mesenteric artery. We are protecting the autonomous nerve. We are following the duodenojejunal junction, and we reach at the inferior mesenteric vein. Just be aware that there is the mesenteric communications. This is another patient. Just divide the inferior mesenteric vein, and then incise the posterior sheet of the visceral transverse mesocolon at the superior border of the pancreas. This allows us to go inside to the bursa mentalis. This is the superior border of the pancreas. Pancreas can be delineated and encountered here nicely. So we could see the bursa mentalis valve from the superior border of the pancreas and the inferior border of the mesocolon. Yeah, here is the bursa mentalis. You could put a swab in order to make things easy from the other side. And then we start the lateral dissection. And be aware not to damage the spleen. So you're taking down the adhesions between the splenic colic adhesions. And then you see the gauze that you put from below, and then it allows us not to damage the pancreas. And this is the pancreas, and this is the stomach, and then this is the full lengthening of splenic flexure to use for a very low cholanal or hamstring cholanal anastomosis. But we have to, make our judgment. There is no traditional dogma, so you have to, sound yourself, listen yourself, access the factors that influence this decision, because difficult and tricky procedures sometimes, but experience tell us right thing to do at that moment. And in not every case we need splenic flexure mobilization, but we have to teach all colorectal surgeons how to make the colon reach. And I would like to thank the society and to the chairmen and to all yourself. Again, selective approach is most likely to benefit the patients. Before stopping my talk, I just want to say that I started doing this and I learned everything from Amjad, and in a short while I'm sure Miljan is going to tell about the Serbian experience, but I came to this level within the last 7 years with the help of Amjad, so I'm sure you will be there soon. I'm still improving, still learning, and thanks for having me.